Thank you very much. And we're now ready for our second panel of the evening. So good evening, everyone. I'm Aisha Lofters, and I have the honor of moderating tonight's second panel. Tonight, we're going to have an important and ongoing conversation on best breast health for Black women. And we're joined by, as Elaine introduced earlier, an incredible group of both clinicians and patients who bring a wealth of knowledge, lived experience, and care to this topic. And we're deeply grateful to them all for being here and sharing their stories and their wisdom. We know that when it comes to breast health, Black women often face unique barriers and challenges. So today's conversation is not only about shining a light on those challenges, but also about sharing strategies, sharing stories, and sharing solutions. So thank you again to our panelists, and thank you to our audience for showing up and sticking around. Your presence matters and means so much. So let's get started. So we have three people with lived experience here today, Colleen, Nicole, and Alicia, and we just saw Colleen's video, but perhaps in that order, Colleen, Nicole, and Alicia, could you share with us your personal experiences with navigating the healthcare system after your diagnosis and then through your treatment process?
So it's Colleen. I'll start. From my perspective for diagnosis as well as treatment, I had an overall positive experience navigating the healthcare system. And, as per my video, it's really about mindset and how I entered into it. I expected the worst when I got my diagnosis. So the emotions prior to getting the diagnosis when I was in the office in February, it was I was already in a mental state of mind where I was like, what's next? What do we got to do? What are my options? And I was already in that mindset. So it was not an emotional moment when I heard the news. It was a, okay, what do we do sort of thing. And then even treatment for me was pretty positive. I had to go through chemo, surgery, and radiation, and I had an overall great experience. I could, create opportunities around that nurse that had to poke me several times to get my, IV in and stuff like that. But overall, I had a great experience. And I think the key thing for me during that time for treatment was that I had a nurse practitioner who gave me her personal number. And I know usually we get information and we get support pamphlets, we get, all this stuff, but I actually used her number for everything. I contacted her, I texted her. She was such a great, powerful resource throughout my whole experience for my treatment. And it wasn't just a matter of I was feeling this way, should I feel this way? She was just so resourceful and she didn't know the answer. She found it for me, texted me back, called me back. So I had an overall great experience. I think I'll finish my thought by saying the one opportunity was probably follow-up. I felt like I was an assembly line patient, whereby at the end of radiation, it was bye-bye, no follow-up, no healthcare system reached out for screening or anything like that. So I think that's where there's an area of opportunity. And mind you, contextually, my journey was just before COVID. So the world turned upside down. So some of the systems to support that follow-up, we were all at a standstill. So that's kind of, for me, my overall experience during diagnosis and treatment.
Thank you for sharing, Colleen. Nicole?
Yeah, I wish I could say that it was as positive as
Mm.
Colleen's experience. I wouldn't say that my experience was terrible because I am still here today, so I have that. However, the moment my primary care physician told me I had cancer, it took about 38 days until I saw an oncologist, which is a lot of time to think about having cancer and not knowing anything about it. Once I was in the system, I did have to chase my surgery. So I did have chemotherapy followed by surgery, followed by radiation. I had to chase the surgery. I had to follow up with the oncologist. They told me it would happen within a certain period of time after I finished chemotherapy, adjuvant chemotherapy, I believe. And I wasn't getting the surgery booked within that scheduled time. And I even, had to bring it to patient relations because his support staff was kind of blaming me for it and saying that, yes, I've called you or I've scheduled this and it in fact hadn't happened. Um, Even when I was trying to, prepare for hair loss, I had gone to the hair salon and I was trying on wigs and I asked them, do you have anything that's appropriate for Black women? And they told me no. We used to carry, wigs for Black women or, curly hair wigs. However, they were, quote, difficult to maintain is what I was told in that time and space. And when you're at a really stressful and vulnerable moment in time, you want all the help you can get, and you're turning to the healthcare system and the supports that they provide as experts in this, and to be turned away or disregarded in that way. And my cancer experience, different to Colleen's, was during the pandemic. I was diagnosed in 2023, so some folks might not consider that pandemic, but we were still very much wearing masks. Um, and it was hard to go places. I couldn't find things online. When I was looking for information about what breast cancer would do to my body, specifically radiation and surgery, Google and YouTube showed mainly images of of white women. Even when I was looking at cancers that are shown to be disproportionately affecting Black women, all the content was focused on white women's stories. And there seemed to be like an obvious disconnect to me because it didn't make sense. If the research is saying it's affecting Black women, well, then why don't I see Black women's stories in this? And thankfully, I could turn to Rethink. They had a resource called Uncovered, and I could see, the impact of radiation and surgery on Black women's bodies. And that gave me a comfort there just to be able to know what to expect. And even when looking at what the healthcare outcomes would be for me, that was very difficult because a lot of the research and statistics on breast cancer in Black women come from the US or the UK, and there's a severe lack of data that reflects the Black experience and in the Canadian healthcare context. So, I mean, overall, I am still here and I'm very happy that I'm still here. However, I do think there were opportunities where the healthcare system and care providers could have stepped up, especially in the context, knowing that I come from an equity deserving community. I do feel like we are already at a disadvantage and more work needs to be done to get us on an equitable playing field compared to other folks.
Absolutely. Thank you so much for sharing that, Nicole and Alicia. And thank you for being here on both our panels tonight.
Welcome. Thank you for having me. I agree with Nicole. Diagnosis for me was not a good experience as well. I remember I was diagnosed, I was given the news, and I felt like I was just shoved out to the world with nobody to ask questions to, because my oncology appointment didn't come up till about 3 weeks later. And that's a long time in between to just be Googling everything, and you're just left with your own thoughts. So I found if I had to change anything, I just wish that there was support in between that time, somebody that I could speak to and ask questions to leading up to my appointment. Um, Getting my treatment was great, and I think it was great because I got treated where I worked. So I worked at Sunnybrook in the oncology department. So shout out to my pharmacy peeps. If you guys are on here today, you guys really looked out for me. The nursing staff was amazing. They treated me. I couldn't have asked for a better treatment. Um, but doctor wise, I didn't like it. I didn't like how I was treated by the doctor I had. I ended up switching doctors and I was happy about that. But so diagnosis, not good, but treatment between pharmacy and nursing, wonderful. Um, Thank you.
Thank you, all three of you, for sharing. And I think what your three stories highlight, both the good and the bad, is the importance of us who are healthcare providers and how we can really help people along their journey, or we can hinder people and really make the experience even worse. And it's, as you said, it's not just physicians, it's the entire care team, but we all have to play our part. And I know that there's many healthcare providers who are on the webinar today and who are taking that message to heart. So you touched on this a little bit, but I'm going to ask all three of you again, and perhaps we can go in the same order. What you're comfortable sharing with regards to how your diagnosis affected your mental health, and then also how did you then find the supports that you needed, like psychosocial or mental health supports?
Yeah, so from my perspective, and again, I think it was a little bit displayed in the digital story. especially towards the tail end of it. For me, honestly, the olive branch of hope. So through my photography, I was able to photograph a gala. And I feel like true to my story, I really kept my journey to myself. I was like, it's done. I'm still here. I survived. And I never looked back at it until I was faced at the gala with the words triple negative breast cancer being, just ringing through. And then the emotional side of me came out. As much as I was strong during my journey, and had a mental strength that allowed me to get through at that time, I think of it and I think of myself and I say, if, God forbid anything happened again, where a recurrence, I don't think I would be mentally as strong. And I'd have to lean on some of the support systems that I have, and Olive Branch of Hope is amazing for that. And I feel like my intersection there allowed me to face my journey, brought me to this space where I'm on a panel talking about my experience where I would have never done this a year ago. I would have never come out and said anything, not because I'm ashamed. And don't get me wrong, if I had one-on-one conversations with people, I would share that, hey, I had cancer and slip out like it's just like saying hi. And they'd stop me in my tracks and be like, you had what? So there was a mindfulness that I had to develop that says, okay, I can't just slip out with that. I have to put into context. It fits in the right place, the right time. So big thank you to Olive Branch of Hope, because just to extend upon the intersection and the mental health part of it, I was able to get screenings. They have amazing awareness programs that are in a hospital setting. We are in the lobby. The Olive Branch of Hope has a 5-hour, 4-hour afternoon of panelists that are in the hospital setting, and such an amazing, amazing, amazing awareness. We get free mammograms. I was able to get my follow-up after how many years I was able to go get screening and stuff like that. So again, for me, the empowerment, finding the breast cancer myself, always, it was, again, thank you, Olive Branch of Hope. That's all I have to say for mine.
I'm next. So on the mental health support, I think I'd consider myself really lucky because as soon as my primary care physician told me I had cancer, I asked her to send the referral to my psychiatrist who's at UHN. And I had, because there's a lot of uncertainty when you receive a diagnosis, plus the 38 days I was waiting and just doing exactly what was mentioned by Alicia, Dr. Google, looking and reading at all of the terrible things that could potentially happen. And because I knew how uncertain the future would be, I knew I needed all of the mental health support to get me through it. So even though I wasn't actively getting treatment with my psychiatrist at the time, I had her contact information and she told me how to reach out if I ever needed help. And, looking back at my chart in preparation for tonight, I actually was able to see her before the oncologist, which I take that for what you will in terms of what's going on in the system. And because I had like a 10-year plus relationship with my psychiatrist, and this was an asset because to start that from scratch when you're already in the position of navigating a diagnosis is a lot. You're in desperate need for support. And finding somebody who understands you is really difficult. So having that pre-existing relationship with her means she already understood my needs. She knew how I thought about things and how to talk with me and engage with me in a way that would be productive and fruitful. And she knew my mental health history. So she knew exactly what to potentially look out for. And, if this isn't you, that's okay. Because once I got into the system, the oncologist mentioned that there's an AYA program. And shout out to all the AYAs celebrating Cancer Awareness Week this week. And that team can help you navigate the life changes that comes with a diagnosis, including talking to your schools or employer to coordinate time off or modifications of work, and also connect you to mental health support. And in terms of my actual mental health during the process of diagnosis and treatment, I would say my mind was at disassociation station. That was my mental block to protect me from what was happening. I didn't really have a boo-hoo moment when I was diagnosed. I just wanted to get it started and get it over with, kind of similar to what Colleen was saying. People would ask me how I was doing, and I would just say I'm in survival mode. doing whatever I could do to protect my mind from the things that were happening to my body. And this is where the dissociation comes in. However, it did not last because during my first round of chemotherapy, I developed anticipatory anxiety and anticipatory nausea and vomiting. I had severe reactions to some of the medications, and when I thought about it, I would be unwell. I would start shaking. I would start rocking back and forth. I would also stop talking. I would just freeze because thinking about chemotherapy would put me back into that chemo chair. So to help me with that, my psychiatrist did prescribe me with lorazepam to help calm my nerves before treatment. That way I wouldn't have such severe reactions like physically during the treatment itself. And then throughout the course of treatment, I had biweekly check-ins with my therapist to talk about how I was doing. And eventually I did start to take medication for anxiety and depression, but that was when I was finished most of my treatment. That's when it all kind of set in. I think the disassociation station finally dropped me off. I got at my stop and I was faced with the mental, the heft of the diagnosis. But even throughout all of that, to help me with my mental wellness, I did have the wonderful support of family, friends, and coworkers. I had just moved into my own home when I was diagnosed, so I tried to get outside, go for little walks around my neighborhood when I was well enough. I had people come visit me from, who weren't in the city because that gave me something to look forward to. And my friends would just hang out with me on FaceTime to keep me company so I wouldn't be so alone with my thoughts every day. And that was really helped me build the resiliency that I needed to just get me through every day.
Thank you so much. And Alicia?
Thank you. Diagnosis for me, it was very hard to accept and to hear those words and to accept it. So for the 6 months of chemo, it was really tough for me going through that mentally. I ended up having to go on medication because I remember I couldn't sleep at night. I was just always in my head thinking the worst. I have 3 kids, so I remember I was always thinking I wasn't going to be here for my kids. So I eventually had to go on medication to keep me calm and to be able to sleep at night. And I'm happy that I was able to reach out to my family doctor. Like Nicole said, she already knew me, she already knew my history. So because of that, she was able to prescribe me the right medication. And eventually even though I didn't want to at first, I did finally give in and started speaking to a therapist. And I think that was the best thing for me. She was with me through the course of my treatment. My treatment was very long because I'm triple positive, so about 17 months of treatment. So she was with me for probably about a year through of that treatment, and she was great because she was also a breast cancer survivor. So she was able to understand what I was saying and what I was going through. That's another reason I didn't want to actually speak to anyone, like a therapist, because I'm like, what do they know? They can't relate. So when I actually found somebody that's been down the same road, it was good. It was empowering for me. She was able to give me solid advice. And family and friends were really amazing during my time. I had a friend that would come and walk with me every single day on her lunch hour. So that was amazing. Nobody really left me alone. Um, they gathered around me and just really helped me to feel the support, which I needed because I felt like it was just the worst time of my life. And support was definitely there for me. Thank you.
Thank you again to all three of you for sharing very, very personal stories. But again, I know that people in the audience appreciate it, and hearing just a wide variety of supports, from traditional going to physicians to groups like the Olive Branch of Hope to taking walks to friends. All of these things I think play a role and are all part of our collective village when we need support. So I'm now going to turn to our clinicians. So for Dr. Aganaba, after hearing from Colleen and Nicole and Alicia and their experience, what advice or insight do you have from the clinician perspective that you could share?
So first of all, I just want to thank the three of you for sharing your experience. As a healthcare provider, it means a lot to me to be able to hear from you and to get feedback and to try and improve our services and take better care of you. I think as Black women navigating this healthcare system that doesn't always treat us well, unfortunately, I think we really have to come to face it from an empowered position and from a position where we have as much information as possible so that we can advocate for ourselves. So the first thing I would say is when you go to these appointments, you're going to be asked a lot of questions. And these questions are important because a lot of our decision making and how we treat you depends on how good our information is and how much we know about you as an individual. And it can be overwhelming when you're asked all these questions to try and keep all these symptoms in your head and to understand. So as you experience symptoms, as you notice things, I would say write them down, keep a journal to help you when you go into this appointment. And also, if possible, bring somebody with you, not just for the support, but they can also help because maybe they've noticed things that you haven't. And when you are kind of bombarded with a lot of information, they can also be a second set of ears to listen and to remember everything that that you heard. And that same journal that you bring, that you write down all of your health information, also bring it to write down the things that you hear in the appointment. I think Nicole mentioned that there was a problem with her follow-up with arranging her surgery, that she didn't get an appointment. So when the doctor tells you, we expect to follow up in so and so weeks, write that down. And if they give you any contact information, make sure you have it because if you don't hear and the expected time that you were supposed to be followed up on, you absolutely have a right to call and be like, hey, what's going on? Because mistakes happen. As we know, our healthcare system is not perfect. And you absolutely have a right to ask questions and demand information if things don't feel right or aren't lining up with the information that you have. And then the other thing I would say is equipping yourself with as much knowledge as possible. So just being here tonight, you're already doing a great job because you're hearing from people who've been through it and hearing from us who serve patients in these situations. And that will help you when you go to your appointment. If you hear something that doesn't make sense and you already have a bit of information, you can more confidently push back. And at the end of the day, if you're not feeling comfortable, don't be afraid to ask for a second opinion. Um, at the end of the day, our job is to serve you. And if we're not serving you correctly, I think I'd speak for most of us. We just want you to be treated. And if we're not the right fit, that's okay. Don't be afraid of offending someone. You deserve to be in a place where you feel comfortable.
Excellent advice. Thank you so, so much. And now, the next question for you is about recent changes that have been happening in the cancer screening world. So could you talk to us a little bit, with this audience of Black women, just about the recent changes in breast cancer screening guidelines?
Yes, I'm really excited to talk about this. So in case you don't know, Ontario has a publicly funding breast screening program. And before, it used to screen women from ages 50 to 74 with mammograms, usually every 2 years. But starting in October 2024, that has now been moved to age 40. So in the US, they did models that show that if you screen 1,000 women in that 50 to 74 age group, you can prevent 7 breast cancer deaths. And if you move that starting at age 40, you can add 1 to 2 additional breast cancer deaths averted over a lifetime. And I know 1 to 2 doesn't sound much, but if you multiply that over a population, that's a pretty significant number. And so this is important for everyone, but it's especially important for Black women. So we know that in Canada, Black women in that 40 to 49 age group, though they may have a lower overall incidence of breast cancer, they actually have a higher mortality rate. And this is multifactorial. Part of it is, these social determinants of health and inequitable access to healthcare resources that we all know about. But also Black women can be diagnosed with more aggressive subtypes like triple negative breast cancer, as we've already talked about. And we know that these types of cancers can progress more quickly or have fewer targeted treatment options. So in that case, early diagnosis is key and extremely important. So these changes, they're not just about access, but also equity. And another thing is, I think earlier in the other panel, we talked about how Black women might not be as connected with family doctors. So another great thing about this is that you can actually self-enroll in this program. So even if you don't have a family doctor to refer you, you can still be a part of this program. So tell people about it. I know in a lot of our cultures, don't there's a lot of anxiety around screening. There's a lot of we like to avoid things, but I feel like the more that we talk about it, ask your friends, hey, have you had a mammogram? And just normalize this because it can save lives.
Thank you so much. And just to repeat that, you do not need a referral to have a mammogram if you are age 40 or above in Ontario. You can just go ahead and call the breast screening program site. So now we're going to turn to Dr. Wu. So Dr. Wu, the audience had submitted to us beforehand a lot of questions about Black women potentially having denser breasts and other racial groups, and just how this might impact cancer detection, including for screening mammograms. What can you say to us about breast density?
Thank you. So in the last few years, we've really supported this discussion around breast density. I think it's important to know your breast density and not just know what your particular score is, but what it means. So, taking 10 steps back, density is a rating that should be on your mammogram report, and you will see a score of A, B, C, or D. It's a bell curve. So most of us are in the B or C middle categories. 10% of people have less mostly fatty tissue, category A. 10% have the extremely dense, category D. So, in the recent years, there has been work done to determine cultural differences in terms of density, showing that Black women have denser breasts than white women. And this is important because how do we make screening policies? Who is that based on? So understanding the differences in our approaches and making sure that we are specific to the patient, I think, is something that we will be more conscious of going forward. This mammogram rating, by the way, and if anyone has seen a mammogram, is an X-ray of the breast. So if we think of like a Halloween cartoon X-ray, the skeleton is white. Everything sort of skin and flesh and fat is black surrounding it. So an X-ray of the breast is no different. We don't have things exactly as dense as the skeleton, but solid tumors show up like that. The challenge is when you have denser tissue, you have a higher number of breast cells. And what it translates to in the picture is kind of like a blizzardy picture. So what I always say is we're looking for a snowball in a blizzard. And if you have fatty tissue, we're looking for a snowball on a clear blue sky day. So not only do patients with denser tissue have more snow, right? There's a higher number of breast cells. We see a little bit less well. I think commonly people think, well, we can't see at all in patients who have dense tissue. That's not true either. We just see a bit less well. What it means for you is, I think about breast density when I interpret an imaging finding. How well did we see? I think about density when I think about the next time you should have your screening. Am I actually comfortable letting you go 2 years if we didn't see as well this time around? And so this is now part of the conversation that we hope you have with your practitioners, that we hope whoever is ordering your mammogram thinks about. The average risk screening program that Dr. Aganaba just talked about will call you back every 2 years. And my advice to you is you actually might not be the person who should be called back every 2 years if you have extremely dense tissue. You actually may need to advocate for imaging more frequently because again, it's not about me, but we might feel less comfortable letting you go the full 2 years, even if you have no risk factors. When we think about Black women getting diagnosed with more aggressive breast cancer at younger ages, this is happening in a population when no one's even looking out for you. So now in Ontario, you can advocate for yourself and refer yourself for breast screening. And then what? You know, you have one set of breast imaging, which is wonderful this year. I'm thinking about the next one and the one after that. And so breast density is something that certainly comes into the conversation in my mind when I think about how to advise you in terms of going forward. And of course, we marry that with what it is that you want to do. It's a common also assumption that breast density has something to do with how your breast tissue feels. In fact, it is unrelated. Breast density is strictly a mammogram rating. You can have very lumpy, bumpy breast tissue on your exam and have very fatty breasts that is clear as a blue sky on your mammogram picture, or you can have vice versa. Breast tissue that's easy to examine because there isn't sort of a lumpy, bumpy landscape under there, but on mammogram, it shows up extremely dense. So I find that we sometimes confuse those conversations. And so just something to remember that density is based on your mammogram only. And we really do think about it when we think about how often to screen you.
That's great, Dr. Wu, and thank you for clearing that up. That is a common misconception. Another really popular question that comes up is about breast pain, which is very, very common, including, you know, during perimenopause, as we talked about. So when should people be worried about breast pain?
So breast pain, you know, draws our attention to the breast tissue. We never dismiss breast pain because, you know, this is a symptom that your body's experiencing and it warrants a conversation and evaluation. The truth is, we actually don't often equate breast pain with breast cancer. So in the clinical world, breast pain is very rarely a symptom of breast cancer, but it's not never. And so there used to be a really old saying where if it hurts, it's not breast cancer. And now I say, you know, we can't hang our hats on that. We have to actually investigate it. You deserve some imaging, particularly if it's in one spot and if it's all the time. Breast pain is very common and it fluctuates with your cycle. And if it comes and goes, I don't often worry about it. But breast pain that is in one spot, doesn't go away, absolutely warrants targeted imaging to that area. And as we talked about perimenopause and menopause earlier tonight, the breast tissue goes a little bit wild during the perimenopausal transition when the hormones really start to change. And so we don't have a nice organized sort of rise and fall with your periods prior to perimenopause. We have this up and down roller coaster type experience, and the breast doesn't really get that, you know, engorgement and release that it might have gotten previously. So we see a ton of women in the breast center in the perimenopausal age range, in early menopause, when the breast maybe starts to hurt for the first time or it's getting worse over time. We're always happy to see you. I think it is something that's commonly dismissed, but from my perspective, even if we see you for some education, reassurance, making sure that your imaging looks okay, I think that's worthwhile.
Excellent, thank you. And before we open it up to the Q&A, I'm going to turn it back to Colleen, Nicole, and Alicia. Just if you have any last messages that you want to share about breast health.
From my perspective, I really think you have to empower yourself to take charge of your own healthcare journey. One of the things that I want to really empower my daughter to do is speak up. She's 14 now, and you know, as she gets older, and hopefully she doesn't have to enter the healthcare system the same way that I did, but you have to empower yourself to take control of your healthcare journey. And you have to ask questions. You have to knock down doors, and you have to get support from outside the system. And I think the one thing that I'd say analogy-wise, we send our kids to school. We expect the school system to educate them, prepare them for university or whatever, extended education. But we know that we can't rely just on the school system, just like we can't just rely on the healthcare system. We have to look for supports, whether it's our family, whether it's support groups, whether it's awareness groups, we have to empower ourselves not to rely on one institution to support our journey. So I would say take control of your journey and not rely blindly on the healthcare system to support you through these really, really crucial times in life.
Um, for me, I think that like earlier, or one of the things I would say is knowing your family history. However, I'm thinking back to the land acknowledgement, many Black people here are here by force. So it's not uncommon to not know your family history simply because you do not have access to it. It's not intergenerational knowledge that's passed on. And then sometimes there are also some cultural barriers that don't create the environment in which this information is talked about and shared. So with that in mind, know that it can happen to you. When you're young, you think you're invincible. It couldn't happen to you or not at this age. I'd always say, I'm like, why did this happen now? Hit me up when I'm 60 or 70. Like, at least I will have lived some more life as I am right now. However, since if you don't know your family history, then it's really important to know your body and know when something is off. For me, I had an occult breast cancer. I had a lump on one side of my body and my lymph nodes, and I didn't have a lump on the other side. And it was that triggered this whole process of getting an ultrasound, getting a biopsy, and then eventually getting a diagnosis. And I know it's more than one thing, but I also do want to say to support small local grassroots organizations like Rethink Breast Cancer and the Olive Branch of Hope. They are all working to fill in the gaps in care that our healthcare system does not meet. And they are the ones that are moving the needle in terms of advocacy for Black women to improve our health outcomes. And I think it was like Olivia that mentioned it earlier, culturally competent care needs to become the standard, not the exception. And these are some of the groups that are helping to advance that and advocate for that.
Everything that Colleen and Nicole said is exactly what I would say. You have to advocate for yourself. You have to advocate for yourself. And at work, we see patients actually do better when you know what's going on with your own health. You cannot leave it up to the doctor alone. And you cannot just take what the doctor is saying and not do your own research. I was told to get a lumpectomy. I went against that and I got a double mastectomy. You have to do what you feel is right for your own health. And Black women, you cannot think, oh, I'm too young or I don't have family history. This will never happen to me. It will happen to you. I was young. I had no family history. It happened to me. So, it doesn't discriminate who you are, whether you're rich, poor, Black, white, anybody. It can happen to anybody. So continue to do your self-breast exams every single month and bring it up to your doctor if there is anything that's off. Do not wait because the early detection saves life. So please, if you can take away anything from tonight, just take away that early screening, get your mammograms, do your self-breast exam. Do not just leave it and do nothing. Please say something. Thank you.
Thank you. Knowledge is power. I'm looking at the questions in the chat, and I think one issue that's coming up, which maybe I'll turn to our clinicians, is about what is the role of, we've talked about density, like what's the role of ultrasound and MRI? Either of our clinicians to speak to.
So the only screening test that has known benefit in terms of saving lives is mammogram. So that is why it remains the main test that we use, despite the challenges around density. Ultrasound is studied as a adjunct, meaning that if you add it to mammogram, not replace mammogram with ultrasound, but if you add it together to mammogram, it can probably detect 1 to 2 more cancers per 1,000 women. And so ultrasound alone is not recommended as a screening tool. There's a lot of variability between you doing an ultrasound and me doing an ultrasound. I may find something, you may find something, we may miss things. There's no real constant way we can ensure that all the tissue's covered equally. And so it's used as an adjunct, or it's used to target an area to explore a finding on a mammogram and give us more data about a particular region. The MRI cuts through density. The challenge is it is an expensive test. There aren't very many spots available, and so currently it's reserved for those patients who are the highest of high risk in Ontario to receive their annual screening with mammogram and MRI. Occasionally it's used as a problem-solving tool, but by and large, your family doctor can say, I agree with you, I think you should have an MRI, and they will try to order it, and radiology may decline it. It's heavily governed by the radiologists as a problem-solving tool and a high-risk screening tool. The reason is it's good at cutting through density, but it's not very specific in telling us what it finds. And so what happens is it finds every little speck of anything in the breast tissue, and after that, you end up needing more tests to figure out what all these little flecks are. And by and large, most women don't require all of that imaging, and it does more harm than good because all of that testing and potential biopsy and waiting for appointments and waiting for results has measurable harms in that process. So there's no easy answer to this question. I think the density question is going to be answered hopefully in terms of clinical guidelines in the coming years. Right now, you're going to find differences in what people are doing in terms of patients who have category C or D breast tissue, but it also depends on what your risk factors are. Once again, coming to an event like tonight is all about education, self-advocacy, and empowerment. So if the person before you is not so well versed in this domain, ask for a referral, right? We're always happy to see you in the breast center. We're always happy to provide support to whoever's referring you to screen you the best that we can.
Thank you so much. And then another clinician question, I'll ask Dr. Aganaba this one. Another kind of hot topic, which is the role of self-exam. So, we hear stories of people who found their own breast cancer, but then we hear self-exam is not recommended. So what is the role of self-examination and what's the story?
So I'm someone who, especially, tonight hearing from Black women who may not have as equitable access to care, who may not be seeing their family doctors as regularly, I do think that self-exam is a good thing. And it's true, you might not have an idea of what feels normal, what's not normal. Breasts can be very lumpy and bumpy. But one thing that's really helpful is to be aware of what your breasts usually feel like. So you know yourself, you know what your normal is. And then if there is a departure from that normal, you can be proactive in then seeking medical attention and having someone have a look at it. And so this is not just feeling your breasts and feeling the tissue, but also looking at your breasts. Be comfortable with looking at yourself in the mirror and knowing what the skin looks like, what the nipple looks like, so that, again, if there's departure from that normal, you can go to a doctor and say, and look, this is not normal for me. I know what my breasts normally feel or look like, and you can really advocate that somebody investigates that.
Thank you. There was another question, and I'll warn you, this is a tough question, about the interplay between chronic stress, racism, and cancer. So is there anything that we know from the literature? I mean, I think we heard some stories where, we see it playing out, but is there anything that we know about that interplay between stress, racism, and cancer?
So I don't know. Go ahead, Dr.
No, you go ahead. You go ahead.
I was just going to say that I personally don't know of any specific studies measuring the relationship between stress and breast cancer, and especially in Black women. But as a physician and as a family physician, I know that stress has a huge impact in our health overall. And unfortunately, we know through systemic racism as Black women, we do have higher levels of stress. And so I think that, self-care and advocating for yourself and addressing that is vastly important for your health overall. And, in situations like this, maybe if you are a patient who's dealing with a breast cancer diagnosis, who's going through the system, leaning on your family doctor or nurse practitioner, if you have one, is super important, as we've seen from, I think Colleen and Nicole mentioned it as well, because it's true, they have a more holistic view of you as a person, and they're usually thinking of your health as in a broader spectrum, whereas a specialist might be more focused in on that specific cancer care. But your mental health is just as vital as treating your cancer, whatever diagnosis you have, and it should absolutely be addressed.
Thank you. I think we could probably go on, and I know that there's lots of great discussion happening in the chat too, but we do want to be respectful of your time. So I think we'll pull up our key takeaways slide now. So this has been a really wonderful panel. So thank you to all of you, the panelists, for attending, and to those of you listening. So what we're hoping you're taking away from this is that early diagnosis can save lives. We've talked about the importance of knowing your body, being breast aware, being comfortable with how your breasts look and feel, and identifying where there might be a concern, because that can really make a difference. Booking an appointment with your primary care provider, if you have one, if there is a concern. A reminder again that if you're over age 40 and you want to book your mammogram, you don't need a primary care provider to do so. And we've got a QR code here, so please be sure to scan it with regards to booking your own mammogram. Know your family history when possible. Genetic testing is available for those with a strong family history. We've talked about the importance of healthy eating, regular exercise. Please don't be afraid to ask questions, to ask for help. If whoever you're asking isn't giving you the answers, find someone else. It was mentioned in the chat about, going to patient relations. Do so if you're not getting the answers that you deserve. You have a right to have your questions answered, and you have a right to healthcare. So thank you all very, very much, and we will see you next time.